Okay guys, we are back and covering the posterior pituitary. Should be the last lecture for today / tomorrow. Alright, let's get started. Quick recap of the previous lecture of the anterior pituitary. I thought this was a good picture to describe what we covered. Remember, we covered like high prolactin levels in women, high prolactin levels in men, and what the effects would be. We covered, growth hormone secreting tumors, and we will cover this later. But just for future reference, when you have this specific disease, an ACTH secreting pituitary tumor, it's called Cushing disease. And Cushing disease is a type of Cushing syndrome. It's kind of confusing, but we'll get to it later. Oh yeah, I wanted to correct something and just marvel at how awesome this slide is. I'm really proud of this slide. This statement here is different than this statement. I connected them last time, but what this means is that high growth hormone levels can over time actually predispose to diabetes or make it more likely to have diabetes because of decreased tissue sensitivity to insulin. That same decrease in sensitivity happens in type 2 diabetes. It's the cause of the disease. So sometimes these patients can present with symptoms of diabetes as well. And this was just the reason for the oral glucose tolerance test. Okay, oxytocin and ADH. And even though they're discussed under the posterior pituitary, remember they're actually made in the hypothalamic nuclei. And then they travel down with their partners called neurophycins, right? And then they sit in the posterior pituitary in herring bodies. That storage site, remember, just waiting to be released into circulation. All right, oxytocin. Everybody knows about oxytocin, right? The love hormone. It's responsible for pair bonding in animals and like monogamy and all that stuff. But physiologic actions that are more direct and less complicated. In the uterus, it causes contractions, and during birth, which I remember learning in OB, or in the repro system, it's called parturition. Parturition, aka birth. But that is where more oxytocin causes more oxytocin receptors and like all this stuff. And that's a classic example of positive feedback, right? In the mammary glands, it causes milk letdown, which is sort of different from the function of prolactin, right? Because prolactin was like more synthesis, and this is more like milk ejection, I believe so. So like when the baby latches onto the nipple and there's ejection, that's oxytocin. ADH, we'll spend most of our time on. Hopefully this is review for you, but definitely very high yield. And smooth muscle cells, it acts on V1 receptors. It causes vasoconstriction. And then it acts on V2 receptors in the kidney, and remember it causes the translocation of the aquaporin channels from the cytoplasm to the cell membrane, which allows water to kind of follow its gradient and be reabsorbed back into the bloodstream. And it's free water, right? Okay, so this is a great example, ADH, aka vasopressin, great example of what I talked about in the first lecture and the first unit of this class, about how the receptor really determines the function. So if we look at the V1 receptor that causes vasoconstriction, that's that pressor effect, that increase in blood pressure, and it acts via V1 receptor, which, as you can see here, IP3 mechanism means it's linked to what G protein? GQ, right? You get IP3, you get a large increase in calcium, and remember, GQ, increase in calcium, a lot of that stuff is very closely related to smooth muscle contraction, which in this case is the smooth muscle lining the blood vessels. And the easy way to remember, angiotensin 2, ADH via the V1 receptor, and alpha 1 all cause vasoconstriction at the blood vessels, and they all do it with the same G protein mechanism. The V2 receptor, I talked about that, so you guys should know all about this from renal. That's the kind of ADH effect, so it works out to use the different terms, for the different functions. Okay, I wanted to kind of discuss or try to tie in a lot of concepts that you had, renal, cardio, and endocrine, and there's a lot of crosstalk. I'll just get into it. Okay, so ADH and aldosterone sort of work in tandem, right? And they're actually both increased by activation of the renin, angiotensin, aldosterone system. Although ADH is, I won't get into the specific differences here. Just know they work in tandem, right? They have similar effects. They both want to raise blood volume. They both end up raising blood pressure. Okay. ANP, on the other hand, which you just had in cardio probably, is activated by atrial stretch, right? Or when there's that force on the walls of the blood vessel, and you need to natriurease, right? Atrial natriuretic peptide. And this is how I always wrote it when things were inverse. So ADH and aldosterone work in tandem, and then they're kind of equal and opposite to the effects of ANP. And one inhibits the other, like ANP inhibits things over here, and sometimes this side can go over and inhibit that side. So a lot of crosstalk. Okay, in a situation where you have excess ADH secretion, obviously it hits the V2 receptors, right? The free water gets reabsorbed. Now all of a sudden we have an increase in blood volume. And this is just a great example of all three of these working at the same time in different ways, right? Okay, so if we have an increase in blood volume from the ADH, we're reabsorbing a bunch of free water. That increase in blood volume is actually going to mean a decrease in aldosterone, because we don't, the renin system responds to low blood volume. So if there's a massive ADH release, a massive increase in blood volume, there's actually going to be less aldosterone, and that means there will be a loss of sodium in the urine. Okay, in addition, this increase in blood volume means the heart will sense that wall distension right on the atria and will release ANP, and that will cause a further loss of sodium in the urine. And this is really, this cycle caused by massive continuous increases in ADH is the reason you can have a really deadly hyponatremia. I'll talk about that in the next slide. Anyway, that was kind of messy. I hope that made sense. SIADH. These are the classic buzzwords. SSRIs can cause it. Carbamazepine, which is a seizure medication, and it's used for some other things. Anti-seizure medication. And then this is like the big daddy, small cell lung carcinoma. You'll see this over and over again. The urine is concentrated, right? Because like the previous slide, if we have a lot of ADH, we're reabsorbing free water, which means you're going to be peeing less, and the pee is going to be very, very concentrated. And worst hyponatremia you'll ever see. If you see a test question with a sodium level of like 105 or 115 or 118, then you should immediately be thinking SIADH. It's a dangerous and dilutional. So if you can't really remember the full mechanism on the last slide, just think that there's going to, at the very least, be a dilutional hyponatremia, because the ratio of the increase in water is outweighing the sodium that balances it in the ECF, and it's kind of, at the very least, a dilutional effect. You can see personality changes, seizures, cerebral edema. So why is this caused by hyponatremia? If we take it back to Unit 1, remember there's the intracellular fluid, extracellular fluid. In this case, we have a hypotonic environment in the ECF, right? There's less solutes compared to the ICF. So water is going to rush inside the cell to try to even those things out, and that will cause brain cellular swelling, and then that can also lead to seizures and stuff. So that's the mechanism for that. Diabetes insipidus, and this is equal and opposite, right? There's a lot of things that are equal and opposite. SIDH is really the exact opposite of diabetes insipidus. You have an excessive loss of dilute urine. There's three types. Psychogenic is, often seen along with mental illness or a history of abuse or PTSD. It's pretty much all in the mind, but the mind can do some crazy things. Central diabetes insipidus is it's actually idiopathic. I think it's the most common cause, which means we don't really know what the heck is going on. But you'll see trauma a lot on test questions. Trauma to the pituitary stalk or the hypothalamus, any central trauma. And nephrogenic, usually drug-induced as far as test questions go. And the classic is lithium in a bipolar patient. Can cause this. It messes up the V2 receptors in the kidney because these are the guys that are dysfunctional. Whereas in central, you just don't have ADH. Okay, that's why the water deprivation test, has these results. So the first thing you do if you suspect a patient has this, you order the urine osmolality or osmolarity, whatever, and then it will probably be low, right? And then you want to start differentiating between these three. So if you start the water deprivation test and the UOSM corrects, like it should, it is psychogenic polydipsia, right? Because nothing is physiologically wrong. Now, if the osmolarity stays the same, it's still not becoming concentrated like it should, you can administer DDAVP, which is analog to ADH. If after administering it you get a normalization response, that means the problem was you weren't producing it in the first place from the central nervous system, and you have central diabetes insipidus diagnosis. If it's still not corrected, then you know the V2 receptor, the ADH is not able to act correctly in the kidney, so it's a nephrogenic cause. Hopefully that was a review. I don't know if you covered that in renal or not. Again, just another comparison, diabetes insipidus versus ADH. Okay, which of the following is the underlying problem in central diabetes insipidus? I'll let you look over this for a second. And you should get this pretty quickly because I just talked about it. Where's it at? Oh, F. Lack of vasopressin. This would be nephrogenic. This would be SIADH. This would be a prolactinoma, a prolactin secreting tumor. Or the things we talked about, several times now, antipsychotics, cause excess prolactin, hypothyroid, nephrogenic, psychosomatic. This would be the psychogenic polydipsia. And just to clarify, all three of these, polydipsia means they're peeing all the time and they're really, really, really thirsty. These patients will be parched no matter how much they drink. Oh, I guess that can also happen to ADH. It's more known to present with DI, but I guess it can happen in both. So in this previous question continued, we're talking about central diabetes insipidus. What UOSM or urine osmolarity changes would you expect following the addition of DDAVP? So if you remember that little chart, when you add ADH in the water deprivation test to somebody that has central diabetes insipidus, the UOSM should correct, which means the urine should be able to concentrate like it normally would in a healthy person. Because, if you're depriving someone of water, the longer you go, the more concentrated the urine should get, because um, you want to hold on to all the water you can. There are actually these, man, I forget, this like rodent in South America or something like that that can concentrate their urine so well and survive without water that when they pee, it's like a solid yellow crystal. So, pretty interesting. I'm so out of it. Okay, which of the following causes increased aldosterone secretion? This one should be easy. Alright, so it's basically asking what activates the renin, that whole system, and decreased blood volume is the answer. Okay, so fill in the blank. So at the blood vessels, ADH causes, let you pause it if you want, vasoconstriction. ANP causes vasodilation. Oh, that's another thing I forgot to talk about. That's another way in that these two things are opposite. ANP is actually a very, very potent vasodilator, and that goes along with its function of wanting to lower the blood volume and lower the blood pressure. So if you wanted to simplify that little inverse situation earlier, you could say, without complicating it by including aldosterone, you could say ADH is kind of inverse to ANP. In the kidney, aldosterone causes sodium reabsorption is the big one, right? We'll just say that. No, it's other things. And the ANP literally causes the exact opposite, so causes inhibition of sodium reabsorption. Okay, what disease covered in this lecture could theoretically be caused by broken neurophycins? I'm proud of myself for this question. I'll give you a second. Central DI, right? Because if these are knocked out, you can't release ADH from the posterior pituitary. And I am retiring for the day.